Hi everyone, this is Dr. Olson, and today I'm going to be taking you on a tour of the bones of the lower limb as presented in Lesson 3 of your lab manual. But before we dive into those into too much detail, I do want to do a little quick review of some of the material from Lesson number 2, which gave you an introduction to osteology and the anatomy of bones in general. So to start, the adult skeleton has about 206 bones, and their variation in size and shape does have a direct relation to their functions. And we divide these bones into two different parts, the axial skeleton and the appendicular skeleton. So the axial skeleton consists of all the bones that are along the central axis of the body, things such as the skull, the vertebral column, and the thoracic cage. While the appendicular skeleton contains bones of the upper and the lower limbs, as well as the bones that actually attach those appendages to the axial skeleton itself. So the main function of the axial skeleton is to form a framework that's going to support and protect those internal organs, while the main function of the appendicular skeleton is producing movement. Two parts that are kind of the joining portions of these skeletons are the pectoral girdle and the pelvic girdle. So the pectoral girdle is this set of bones that are going to hold the upper limbs in place and connect them to the axial skeleton, and the pelvic girdle are the bones that hold the lower limbs in place and connect them to the axial skeleton. Now, in addition to identifying the bones themselves, we're going to be putting a lot of emphasis on what we refer to as bony markings. And these are going to be components of the bone that have a specific function to them, or they're kind of special for some reason. In many cases, it's because that's a region of the bone where a muscle or tendon attaches to. Other cases, it'll be a part of the bone that's involved in articulation. There might be an opening or a space that a blood vessel or a nerve travels through, and so on. There's a very helpful table, figure 6.17 in your textbook, that groups these different bony markings based on their general structure and then also gives you some specific descriptions of them. By the time we are done with this class, you will be very familiar with all of these, but the sooner that you start realizing that when we're using these terms, it's not just some random name that we've given to this feature, it's actually a descriptive term. I think that's going to help you in learning what these different parts are. The other thing that's going to really help you as you're going through these is to understand some of the additional terminology that's used in describing the body regions. I don't expect you to be able to read this on the screen, it's very small, but I wanted to point out table 1.3 to you, which gives you a listing of essentially all of the adjectives that we use to describe a region. For example, when we refer to the term cranial, we're referring to the skull region. Now, as it applies to Module 1, Figure 1.8 is also going to be very helpful. It is giving you a visual depiction of where these different regions are. And so all of these are terms that you should become familiar with, so that if you're hearing the term curl, you know we're referring to the lower leg. If you hear the term plantar, you know that that's the surface of the foot, the sole of the foot. In addition, there are the anatomical directions that you did cover previously in the lab manual and textbook as well. I'm pointing these out here now because they are going to be used frequently in this discussion and this presentation. So if you do need a refresher on these, you might want to pause the video and go back and make sure that you understand those so that we can use them appropriately. All right, so bones of the lower limb. The lower limbs contain 60 bones total. There are 2 each of the hip bones, the femur, the patella, tibia, and fibula. And then on each foot, you're going to have 7 tarsal bones, 5 metatarsals, and 14 phalanges. And among all of those bones, you're going to find 13 individual articulations on each one of those legs. So we're going to be going through all of those in order, starting at the point where the lower limb connects to the axial skeleton itself. And we're going to begin by looking at the pelvis. The pelvis as a whole is depicted in figure 3.1 of your lab manual. So if you want to go ahead and have that out while we discuss some of these different regions, you'll probably find that helpful. The adult pelvis is a composite structure that's composed of 4 bones. We have the right os coxa, the left os coxa, the sacrum, and the coccyx. Disarticulated, let me give you a little idea of what these bones would look like if we were to take the entire pelvis apart. You can see again here we've got a right os coxa, a left os coxa, and we could combine those with the sacrum to essentially build our pelvis. The coccyx is missing from the sacrum, but we'll come back to that in a little bit. We're going to come back to each one of these bones individually and talk about some of the markings that are on each individual bone. But for right now, we're going to consider just the pelvis as a whole and talk about some of these components. So the pelvis is responsible for supporting and protecting the internal organs you're going to find in the inferior part of the abdomen. The two ossicoxa articulate with each other anteriorly at what we refer to as the pubic symphysis or the symphysis pubis, and they articulate posteriorly with the sacrum on either side. These articulations with the sacrum are what's referred to as the sacroiliac joints, and this is where the lower limbs articulate then with the axial skeleton itself. So before we look at the specific features of the pelvis, I'd like to look at each one of these bones in a little more detail, beginning with the os coxa. The os coxa can also be referred to as the hip bone, the coxal bone, or the innominate bone. And each hip bone consists of three fused bones: the ilium, the ischium, and the pubis. Now at birth, hyaline cartilage will separate these three bones, and then growth and fusion of the three bones into a single hip bone is usually complete by age 25. The acetabulum, which literally means vinegar cup, is a concave socket on the lateral surface where all three of the bones articulate with each other. And then this is also the location of the coxal joint, where the head of the femur articulates with the pelvis. So now, rather than just simply going into details of each of these three bones sequentially, I'd like to use this structure as a way to introduce the various bony markings that we will reference throughout this course. So again, I want to draw your attention to that figure 6.17 in your textbook, and also the chart on 2E in your lab manual. So here's the os coxa that we're going to be using as an example for pointing out all of these features. This one itself happens to be a right os coxa. You can see the lateral side with the acetabulum, and then this is going to be the medial side. So this lateral side is going to be where the femur is going to attach, and we're going to have the hip joint itself there. So the first vocabulary I want to introduce you to in terms of these bony markings is a spine. And a spine is some type of pointed projection. If we're looking at this os coxa, there are 5 prominent spines that we're going to find. And one of my goals in describing the bones this way is to convince you not to memorize what you don't have to. Way too often I see anatomy students get obsessed and overwhelmed with trying to memorize things, when instead I would just encourage you to learn the vocabulary, and that way you can describe something. So for example, you can see 2 spines that we have on this part of the bone. 1, 2, 2 more back here, 3, 4, and then 1 that is sticking out right here. So if we are looking at these, we just simply want to describe them. Let's start with these 2 on this side and these 2 on this side. My first question for you is, which of those 3 bones are those spines on? Are they on the ilium, the ischium, or the pubis? And hopefully you would be able to say right now, well, those are going to be on the ischium. So they're, on the ilium. So those are iliac spines. Iliac is the adjective version of ilium. So we've got 4 spines that are on the ilium. So we need to be a little more specific still. So how can we distinguish these 2 from those 2 back there? We can use our anatomical directional terms. This side of this os coxa that has the more pointy part that we're going to find the pubis, that is the anterior part of the bone, while this is the posterior part of the bone. So these 2 are anterior spines, these 2 are posterior spines. So we can describe them by the fact that they're on the ilium, by the fact that they're anterior or posterior, but now we need to come up with still one more distinction between them. So both of these are anterior, but how do they relate to each other? This one is more superior, this one is more inferior. Therefore, this is referred to as the anterior superior iliac spine, the anterior inferior iliac spine, the posterior superior iliac spine, and the posterior inferior iliac spine. So there you go. That's how you get those 4 spines. They're just the name of the feature is just simply a description of where it's located and what bone it's on. Our last spine that we have down here is doesn't really need a whole lot of description because it's on a different bone. It's not on the ilium. Which bone is that on? Hopefully you recognize that as being the ischium. And so this is the only spine that's on the ischium, so we don't need any further description. We can just simply refer to that as the ischial spine. So there you go. There's all 5 spines that you're going to find on that os coxa. Next term I'd like to introduce you to is a tubercle. And a tubercle is a small, blunt, or rounded process. And the tubercle that we're going to be able to easily identify here is the pubic tubercle. And again, we don't need anything more specific than that, because the pubic tubercle only has, there's only one on there, so we can simply refer to it as that. A tuberosity is a large blunt or rounded process or some type of roughened surface. And we can see that if we look at the ischium here, we have a very large rough portion that's kind of the rounded part. This is essentially the part of your pelvis that you would sit on. I think you would agree it'd be much more comfortable to sit on this rounded, flattened surface than on the pointed part of that pubic tubercle. So this is the tuberosity, and this happens to be on the ischium, and therefore it's referred to as the ischial tuberosity. A crest is a prominent ridge-like projection. Think about the crest of a mountain, if you will. And the crest that we're going to find on this bone is going to be as part of the ilium. So this is referred to as the iliac crest. The iliac crest is the superior part of the ala. The ala as a whole is the wide fan-shaped portion of the ilium, as opposed to the more inferior part of the ilium. A line is a low ridge. So while a crest is a more prominent ridge, a line is going to be a lower ridge. And if we're looking at these lines, we can see, in this case, one more prominent line in this model. I'm going to kind of pull this up here, and hopefully you can even see my pointer kind of going on top of it there. This is the superior gluteal line. You don't get a very good view of that inferior gluteal line on this one. But that line is going to serve as a point of attachment for muscles as well. And then the next term I want to introduce you to is a ramus. So if we're talking about a ramus, that is some type of angular extension of the bone. And by angular, I mean relative to the rest of the structure as a whole. So let's go ahead and we're going to consider a few different rami that are present here. For one, you're going to have, we mentioned before that this was the pubis, and the pubis actually has two rami. So it has one that is going from the pubic tubercle and angling superior, and one that is angling inferior. So this is the superior pubic ramus, and then the inferior pubic ramus. Which again, giving you views from a few different angles here. Inferior pubic ramus and the superior pubic ramus. In addition, we have another ramus that's coming off of the ischium, and this is going to be the ischial ramus. And so the ischial ramus is going to meet up with the inferior pubic ramus, and this is where one of the fusions occurs between those two bones. A notch. If we're looking at a notch is going to be some kind of indentation, a concave indentation. And there are two primary notches that we're going to find on the os coxa. One you can probably see is very prominent, and I'm just pointing it out here. And then a second one is on the same side but a little bit smaller. So both of those are located on the posterior part of the os coxa. And this larger one, a lot of times when we're trying to define or distinguish between two features that are similar but one is larger and one is smaller, we use the adjectives greater or lesser. And this one is larger, so this is the greater, and this is going to be the lesser. And then these specific notches are named for what passes through them. So the sciatic nerve, which I'll learn about in a future lesson in this module, is going to pass through those. So this is referred to as the greater sciatic notch, and then the lesser sciatic notch. Again, give you just a slightly different view here. Greater sciatic notch and the lesser sciatic notch. And then I want to also point out a foramen. This is something that's going to come up a lot in this class. A foramen is some type of hole. The plural of that for multiple holes is foramina. And we can see that looking at the os coxa, there is a very distinct hole right here, quite a large one. And this is referred to as the obturator foramen. There's a strong membrane that attaches to the margin of this opening, and there are blood vessels and nerves that pass through that, including the obturator nerve, and that's partially where its name comes from. All right, so let's go ahead and I'm going to go back to the medial side of the bone and have a look over here. Another term that we want to learn that we're going to see again is a fossa. A fossa is some type of shallow depression. So while we're looking at that acetabulum, you can see why I mentioned that the translation of that was vinegar cup. It's very deep. It's cup-like in structure. If we look at this medial side, this entire part of this medial side of the ilium forms a little bit of an indentation. And so this indentation here is referred to as a fossa, and specifically being on the ilium, it's the iliac fossa. And then we've got a couple other lines that we can see from this area as well. So on the lateral side, we were able to see a gluteal line. Let's look at a couple other ones that we're going to find here on the medial side. The pectineal line is the first one I want to mention. The pectineal line is going to begin near the pubic symphysis, and it's going to extend diagonally across the pubis to then merge with the arcuate line. And the point at which they merge is going to be the iliopubic eminence. So this pectineal line, I'm going to give you a couple different angles on there. You can see how it's very pointed. And then as you come towards that arcuate line, you can see how we get to that iliopubic eminence, which is not a very pointed line anymore. It's just a little bit more of a rough patch there. Eminence meaning something that's sticking out. And then we have the arcuate line, which continues on to what we refer to as the auricular surface or articular surface. Either one of those terms is acceptable. It's called that because that is where it's going to articulate with the sacrum itself. So if we go from that again, articular surface, we're going to follow the arcuate line, pass by the iliopubic eminence, and then continue on as the arcuate line, the pectineal line. So those are the main components of the os coxa. So now let's go ahead and quickly revisit how those are attached as part of the whole pelvis. Again, lateral view, that intermedial view, and then we can see how the sacrum is going to be in between the two of them. So let's go ahead now and take a look at the sacrum itself in a little more detail. So the sacrum is the bone that is part of the axial skeleton, and it's formed, actually is a bone that is part of the axial skeleton, and it's formed from the fusion of 5 sacral vertebrae. And the sacrum articulates superiorly with the 5th lumbar vertebrae, and then laterally with the 2 ossa coxa, and inferiorly with the coccyx. On this specific sacrum, I want to point out this is a real sacrum, and the coccyx is no longer attached on this one. However, this here is an artificial sacrum, so but in this case you can still see the coccyx, the tailbone essentially, that is going to be attached to there. All right, so a few markings that we can look at and examine on this sacrum. I first want to point out the sacral canal. So if we look at, this is essentially, again, just to put into perspective, the same view that we're looking at on the pelvis as a whole. So this is the anterior side of the sacrum. This is going to be the posterior side. The superior side, where that 5th lumbar vertebra articulates, and then also the posterior side where, the inferior side where we're going to see the coccyx articulate. So if we're looking at it from this view superiorly, you can see that we actually have a passageway that goes all the way from the superior side down to the inferior side. And this is referred to as the sacral canal. And so this serves as a passageway for the roots of the nerves of the spinal cord. You'll also notice that there are several little holes that are formed, not only that are visible on this posterior side, but again on the anterior side as well. And if you look carefully, I'm going to kind of angle this, those holes actually connect to that sacral canal. So these anterior holes are referred to as the anterior sacral foramina or the ventral sacral foramina. Anterior and ventral are synonymous in a bipedal organism. And this is where the ventral rami of the sacral spinal nerves are going to come out. And to kind of show you how that would occur, I'm going to pull this out of the screen for a second. Here we go. So we have those nerves that are in that sacral canal, and then you can see how we kind of peek on out not only from the canal, but then we head out anteriorly. We also have some of those foramina on the posterior side, and that is where the posterior or dorsal rami are going to emerge from that sacral canal. So I can go out the same way, but this time one second. There we go. This time I've got this one coming through that sacral canal, but now you can see that once it comes out, it is going to head out the posterior sacral foramina, while I've got the red one here coming out the anterior sacral foramina. So that's kind of showing the route that these nerve roots are going to take, or that the rami of these different nerves are going to take as they're passing through the sacrum themselves. Okay, in addition to all of those openings, we can see on the superior side here, again, this is where I said that the articulation with that fifth lumbar vertebra was going to occur, and so this is referred to just simply as the superior articular surface. The sacral promontory is going to be the anterior edge of that first sacral vertebra that then extends into the pelvic cavity. So you can see how, if we're just looking at this straight, let's go ahead and tip it superiorly, and we can see that there's a definite curvature that would go into that pelvic cavity. This is going to be important, so keep that in mind, that sacral promontory. We're going to come back to that one. If we look at that posterior side, we can see, I'm going to turn this on its edge here, that there is a ridge along the center of the sacrum on the posterior side, but it's divided into, kind of has multiple little peaks, almost like little mountains on the mountain ridge itself. As a whole, that entire structure is referred to as the median sacral crest. And then each one of those individual projections is referred to as a spinous tubercle. So now that we've taken a look at the os coxa and the sacrum, we can go ahead and return to the entire pelvis as a whole. So if we go back to this pelvis as a whole, you recall I told you to keep in mind and remember that sacral promontory, so that part of the sacrum that is sticking out and protruding into that pelvic cavity. We can follow along that sacral promontory, and we can see that just as we pass that sacroiliac joint, we come to the arcuate line of the ilium. From there to the pectineal line, pubic symphysis as we move on to the next os coxa, again the pectineal line, arcuate line, and ultimately back to the sacrum itself. That entire circular rim is what we refer to as the pelvic brim. Think about that as kind of being analogous to the rim of a basketball hoop. So the opening that encloses is referred to as the pelvic inlet. So keep in mind, the pelvic brim is a bony marking itself. It's made up of bones. The pelvic inlet is the space that those bones surround. That pelvic inlet, and that is what separates what we refer to as the true pelvis from the false pelvis. So think about this as being analogous to, that pelvic brim as being analogous to the rim of a basketball hoop. So if we were a ball and we're up above that rim, we haven't scored a basket yet, all right? But once we pass through that inlet, we're going through that pelvic inlet, now we're into the part of the basketball hoop that would have the net. Now we have a basket. We have a true basket at that point. So once we are inferior to that pelvic inlet, that is what's referred to as the true pelvis. All of this region up above the pelvic inlet is referred to as the false pelvis. So right now my fist is in the false pelvis. Here my fist is in the true pelvis. So while the pelvic inlet is how we get from the false pelvis into the true pelvis, we get out of the true pelvis through the pelvic outlet. And that's formed by kind of an imaginary circle that you could form between the ischial tuberosities and the coccyx itself. I do also want to point out the differences between a male and a female pelvis. This one that we've been looking at here is actually a female pelvis. And this second one that I'm bringing up here is an example of a male pelvis. So to point out a couple of the things that are different from them, I want to point out four main things. For one is to look at what's referred to as the subpubic angle. So if we look at, let's start on this female one, the pubic symphysis, I want you to follow the angle from the pubic symphysis down by the inferior pubic rami. So we can see this angle and then compare it to this angle right here. And you can see this pelvis that is on the right side of the screen has a much smaller subpubic angle than the one on the left side. This one right here on the right is a male, and this one here on the left is the female. One of the results of having that larger subpubic angle in the female is that the pelvic outlet is larger. And sure enough, if we go ahead and we look at this, again, our pelvic outlet from our coccyx to the two ischial tuberosities. Compare that then with the pelvic outlet of the male. And you can see that it's certainly much larger in the female, even though if you were just looking at these side by side, they look very similar in size, but when you look at those outlets. And as I'm sure you can imagine, one of the things that assists with is having a larger space available for childbirth. Another thing that you can notice is that just as the pelvic outlet is larger, the pelvic inlet tends to be a little bit larger as well. And so you looking at it from this angle, you can see the difference between those two inlets. And then the last thing I want to point out on these models is kind of the angle at which the ilia flare out. So we can see here on this individual that the ala portion of the ilium kind of heads out a little bit more laterally, while the ones on this male model just stay a little bit more vertical. And so by allowing that to happen on the female side, it again provides a little bit more of that support of that additional weight. I do want to draw your attention to table 8.1 from your textbook. This provides a very nice comparison of the female and the male pelvises, both from that anterior and medial views. So I'd spend some time, because you don't have these two models directly in front of you, looking at this table and making sure that you understand where some of these differences are. The last thing that I wanted to point out about the pelvis are the pelvic ligaments. These are going to become more important as we start to discuss some of their functions a little bit later as we move through this course. But hopefully you recall the difference between a ligament and a tendon. As well, a tendon either connects muscle to muscle or muscle to bone. A ligament just connects bone to bone, or parts of a bone to each other. In the case of the pelvis, the two that we're concerned about are the inguinal ligament and the sacrospinous ligament. The inguinal ligament it attaches to the anterior superior iliac spine and to the pubic tubercle, while the sacrospinous ligament goes from the sacrum to the ischial spine in order to form a space that's bordered by that greater sciatic notch. So let's go ahead and look at these on the actual pelvis model, or where these would be located on the actual pelvis model. So again, if we were to form and create that inguinal ligament, we would want to go from the anterior superior iliac spine to the pubic tubercle. So we would essentially have a ligament that looks like this if I was using my pipe cleaner to make a ligament. On the other side, just like that. On the posterior side, the sacrospinous ligament is going to go from the sacrum as a whole, but connecting the sacrum to the ischial spine. And so now you can see by this, you see how I've created a space right there that is bordered by that greater sciatic notch. And so that is a space that's being created by the presence of this ligament. Articulation-wise, we've already mentioned a few of them. We talked about these sacroiliac joints that's between the sacrum and the ilium. Two of those. We have a single pubic symphysis here on the most anterior part. And then the last articulation that is going to be part of the pelvis is where the hip joint is actually occurring. So at the acetabulum, and that's where the head of the femur is going to fit in there. And you can probably tell by the depth of this cup, by the depth of this space, that is going to be a pretty stable joint. So now we're going to move on to the rest of the bones of the lower limb, starting with the femur itself. I'd recommend during this next part that you have figure 3.5 available from your lab manual. This is going, as we go through all of these bones, I think it's good if you follow along in your manual, because it's going to be listing all of the different features that you should be able to identify in these bones. Make sure that you're labeling them on your actual bones, on the images that are there, and then I'm going to be pointing out those same features on the bone models that we have as well. So let's start with the femur here. The femur is the longest and the heaviest bone of the body. Proximally, it articulates with the acetabulum of the os coxa, and distally, it is going to articulate with both the tibia and the patella at the knee joint. So if we start at the most proximal end, this rounded part that fits into the acetabulum is referred to as the head of the femur. And you'll notice that in the head, there is also going to be another small little depression, and that is referred to as the fovea capitis. At this point is where you're going to find a stabilizing ligament that attaches to this location of the femur, but then also into the acetabulum, and that helps to hold it in place. So if I just quickly bring up this os coxa, you can see approximately how that femur would fit into the acetabulum. So keeping our attention here at this proximal end, coming off of the head, you can see how there's a narrowing of the bone there, and then that's referred to as the neck. And then the neck itself is going to join with the shaft of the femur. So the shaft is the longer, thin part of the femur. It's the longest part of the bone, and you'll also notice that it slightly curves around its length. So if I was to set the bone on the table here, you can see it's not entirely straight. I can set it here, and it's even kind of up and not completely in contact with the table below. So it's got a slight curve to it. If we turn this around and look at, especially at the posterior part of the bone, you're going to see two large, rough trochanters that project from that junction of the neck and the shaft. I've got one of them right here, and then one even larger one right there. This is the greater trochanter, which projects laterally and superiorly, and then the lesser trochanter, which is going to project more medially and is also a little bit more inferior. Both of these are going to be locations where large tendons are going to attach to the femur. Now, as a general rule, you'll notice that these trochanters are very rough in texture. Okay? When if you look at something like the head of the femur, it's very smooth. As a general rule, if you're looking at a bony marking that is smooth, it's probably going to be part of some type of articulation. While if you have something that is really rough, that is probably going to be a point of muscle attachment. The roughness increases the surface area, and so that allows it to attach even better. So that should right off the bat point out to you, if you're looking at this end of the femur, we'd expect an articulation with this bony marking. We would expect muscle attachments with those two. The other thing that you can kind of generalize here is, well, if both of these are points of muscle attachment and one is quite a lot larger than the other one, I think it's a pretty safe bet for you to say that more muscles are going to attach here than are going to attach there. And so you can keep that in mind later as we're learning about these muscles again. Just inferior to those trochanters are going to be locations where large tendons are going to also attach to the femur. And this is where we're going to find on the medial side, coming off of that lesser trochanter, what we refer to as the pectineal line. And then coming just inferiorly from the greater trochanter is this rough patch that we refer to as the gluteal tuberosity. You've already heard the term tuberosity before. So recall that that's a rough patch, and the fact that it's called gluteal is probably going to lead you to think that there's some gluteal muscles that will attach there, and you would be correct. This line right over here, the pectineal line, you might say, well, we've already heard that before, and indeed you are correct. There was a pectineal line on the os coxa. It just so happens that the muscle that originates at the pectineal line of the os coxa and inserts into the pectineal line of the femur happens to be called the pectineus. So that's where those are going to get their names from. I know sometimes those lines can be a little difficult to distinguish on the actual bones themselves, so I'm zooming in a little bit here on a photograph of the bone that I've taken. And as you can see where there's the greater trochanter and the lesser trochanter, and if we're looking at that posterior view, we can see one line coming down from that lesser trochanter. We can see the rougher edge, that rougher surface where we're going to find that gluteal tuberosity. And then those 2 points, when they come together, are going to result in the linea aspera, which is the larger line that's going to be coming all the way down the rest of the femur itself. So coming back to our model that we have here, again, we can see that pectineal line and that gluteal tuberosity. And as we get into the shaft of the femur, now we can see where the linea aspera is. I'm going to kind of zoom in here and kind of rotate this so you can see how that part is sticking up. It's kind of as if I was to pinch the bone a little bit there. So that linea aspera comes all the way down. There are several muscles that are on the posterior part of the thigh which are going to be attaching there. And then as we come down distally, that linea aspera is going to divide into two low ridges that then angle towards the medial and the lateral sides. So we can see it kind of splits and heads this direction and then this way right there. These create just a little flattened triangular area that we refer to as the popliteal surface, and this is associated with a muscle of the same name and then also some blood vessels as well. Some people have noticed that, or noted that this triangular region kind of takes the shape of a tent. And if you think about going to a campsite, what do you do there? You pop the tent up. So pop the tent, popliteal surface, if that helps you kind of remember that one. Now you may notice, if we're looking at this distal end of the femur, that the medial and the lateral sides are not quite symmetrical. As a reminder, let's go back to the whole one. So our acetabulum is always going to be on that medial side. So this is the medial distal part. This is the lateral distal part. So if we're coming over here, so again, you might notice that the medial and the lateral sides are not exactly symmetrical in this case. On the medial side, you're going to find a raised rough projection that's called the adductortubercle. And so this part right there that sticks up a little bit more, and again, as I'm rotating this around, you're not going to really see that as much on the medial side, on the lateral side. So that's the lateral side. It's all around, and you can see this larger projection that we have here, which is that adductortubercle. As the name suggests, this will be a point of attachment for muscles that adduct the hip joint. Now, the adductortubercle is immediately superior to the medial epicondyle. And so our medial epicondyle is going to be on that medial side. Again, our lateral on the lateral side. And epi means, it's a prefix that we're going to encounter frequently. It means above. Think about the epicenter of an earthquake. That's the part of the ground that happens to be directly above where the earthquake began. And so both of these being called epicondyles means that they are above the condyles. Now, a condyle, if you recall from our bony markings, is going to be a large, smooth, rounded, or oval structure. And as we could see, we're looking at these condyles that we have right here. Again, this one right here is going to be our lateral condyle. Here's our medial condyle. You'll see how smooth those are. And these are the ones that are going to be associated with the articulation of the knee. So the smooth parts, that's the condyles. So just above them is where you're going to find the epicondyles. And then on the medial side is where you're also going to find that adductortubercle. On the anterior surface, so we were looking at the posterior surface here before and kind of seeing where that popliteal surface is. If we turn this around and focus more on that anterior part, we're also going to see another smooth kind of depression here in between the two condyles that's referred to as the patellar surface. And as that name suggests, this is where the femur articulates with the patella, or casually referred to as the kneecap. This image here is giving you an inferior view of the right femur with the patella intact. And so you'll notice that the patella makes more contact with the lateral side of the femur than it does with the medial side. So you can see with that red line, I've drawn the contact on the lateral side, while the medial side doesn't have as much contact. Because of that, if you were to take a patella off of the femur and simply lay it on the table, we tend to say that the patella is going to lean lateral. It's going to lean lateral. So what exactly do I mean by that? So here are two patellas, and one of them is a left patella and one of them is a right patella. There aren't very many features that you need to be familiar with in terms of the patella itself. This is going to be the anterior surface, the rough side. That's where we're going to have some tendons attaching. And then on the posterior side, you're going to see that there's a nice smooth area. And that nice smooth area is going to be where the articulation with the femur is going to occur. Now you'll note that the patella is kind of shaped almost like a Superman shield, if you will. It's got a very pointed part that goes inferiorly, and that's referred to as the apex. And then you have the base, which is the top, more flattened part. And so you'll notice that if I set this down, that when I let go, it's going to tip over. And it's going to tip that way. And if I try to tip it back to this side, it's going to fall back over. And so the patella is always going to lean lateral. So if I know that this is inferior and this is posterior, if I know that this is inferior and this is superior, so this is where the femur is, this is where the lower part of the leg is, I should be able to tell that because this is leaning lateral, in order for this to lean lateral, this is going to be a right patella. Notice on the other hand that this one is the exact opposite. If I was to take this one and tip it, it tips back that direction instead. Sorry, I know it's going a little out of focus when I do that. So in this case, looking at the way that those lean, This one is going to be a right patella, and that one is going to be a left patella. Okay, so here I've got another femur, but this one is actually articulated and attached to some of the other bones. So we can see what this knee looks like as a whole. So if I'm gonna go ahead and we can see our patella here, I'm gonna bend this knee, and you should be able to recognize some parts of the femur that we've already talked about in our other model. So here we've got that patellar surface, and there are the lateral and the medial epicondyles. And so you can see how that patella fits there. You can also see how the femur is going to articulate with the bone that is immediately distal to it, that being the tibia. And so you can see how we've got our condyles of the femur are going to fit into these little smooth depressions here on the tibia, which are also referred to as condyles. So those, this is how that the knee is essentially assembled. And so we're going to look at a little more detail at the tibia here and then come back to the knee itself. So the tibia is the large medial bone of the lower leg. And from the proximal end, you don't see a whole lot of difference between the medial and the lateral sides. If we follow this on down to look at the more distal end, you can see that it's definitely not symmetrical. And we can see that one side of it has this large projection sticking out there. That projection is going to be representative of the medial side of the bone. And it's referred to as the medial malleolus. Malleolus means hammer. So let's go ahead, now that we know that this is the medial side, if we were thinking about this leg sticking out here, this would obviously be an example of a left tibia. So let's go back to that proximal side, now that we just at least know that we're talking about a left side. Earlier we're looking at the condyles that were present on the tibia, and so we can see here, again, noting that this is the medial side, this is going to be the medial condyle of the tibia, and then this is going to be the lateral condyle. And you'll notice that right in between there's a little rough patch. I'm going to turn this so you can see how that rough patch is even raised up a little bit. That is referred to as the intercondylar eminence. So an eminence, remember, is something that's kind of sticking up like that iliopubic eminence. And this is the intercondylar, literally meaning in between the two condyles. On the anterior side, just distal to the condyles, is a very rough patch, a very rough and prominent bony part here that's referred to as the tibial tuberosity. You should very easily be able to feel this on your own leg. So go ahead down below just by your knee, and on that anterior part, just feel for this real rough patch that's pretty close to the skin. And there are some very strong muscles that are going to attach there. As we continue down the leg, you should also be able to feel this entire long pointed part of the tibia. The tibia isn't a circular bone. If you look at it, it's almost a little more triangular in shape. And so you can see, again, if we're looking down the front of it, this really pointed part that we have here. And that's referred to as the anterior border. This is the part of the tibia that you can feel as you go down your entire leg. On the lateral margin, so again, remember this is the medial side, so this is the lateral side, you can see another little ridge here, and that is referred to as the interosseous border. The interosseous border connects to another interosseous border on the medial side of the tibia's shaft, and that's going to be the interosseous border on the fibula. That in these two borders, on both the tibia and the fibula, are going to serve as points of attachment for the interosseous membrane, which is a sheet of connective tissue. Now, as we head more towards the distal end, you're going to see the tibia is going to narrow a little bit, and then it has that large projection of the medial malleolus. Another feature that I want to point out to you that's on the posterior side of the tibia is what's referred to as the soleal line. You can see shadow-wise, especially as I'm turning it this way, a line that appears kind of on an angle. It's going from that lateral part of the tibia and then kind of crossing over a little bit. That line that you can see there is referred to as the soleal line. It serves as the attachment point for several muscles, including the soleus, so hence the name. So let's now consider how the tibia articulates with the fibula, or the other bone of the lower leg. So I'm back to this articulated model, so keep in mind this is a right leg. When the disarticulated tibia we were looking at just a few minutes ago, this one happens to be a left. So that's why don't start to think about things being on the left side or the right side, but really try to think about them as being lateral or medial. Between the two bones, as we mentioned, the tibia is the anterior bone and the fibula is going to be the lateral of the two bones. The tibia actually articulates with the fibula at 3 different points. We've already mentioned the interosseous border. So just as the tibia had its interosseous border, the fibula also has an interosseous border. So when these two are present and articulating in a human, you're going to find this border, that sheet of connective tissue between these two bones. We referred to that articulation between the two interosseous borders as being the middle tibiofibular joint. Middle tibiofibular joint. There at the superior end is where you're going to find another articulation between the two bones, and that is going to be the superior tibiofibular joint. And then you're going to find another articulation at the distal end, which is the inferior tibiofibular joint. If we're looking, I want to look at each one of these individually, both in this articulated one and then with the two different bones. The fibula is a pretty simple bone, just 3 parts to it. We have our head, a neck, and then a shaft as well. And then at the other end of it, at that distal end, we have another projection similar to what we saw on the tibia, only because this was on the medial side, it was referred to as the medial malleolus. This one here is the lateral malleolus. Up here at this superior articulation, you're going to see how the head of the fibula fits right into a notch that is on the tibia. And I want to show you those, point those out to you on the disarticulated bones. So here again is that tibia, but recall that we are looking at a left one here. And so here's our medial side. We know this is then the lateral side. So if we follow this up to that lateral side, you can see quite clearly that there is a small little kind of smooth depression here. And that is going to be what's referred to as the fibular facet. So the fibular facet is on the lateral side of the proximal tibia, and this is going to articulate with then the head of the fibula. So if I was to take this fibula and put them together, that head of the fibula would fit into that fibular facet. Okay. At the distal end, is where we're going to find not the fibular facet, but the fibular notch, which is this kind of concave little notch here. And so that fibular notch then is going to articulate with the distal part of the fibula as such. And so that is how we would get our articulation. These two bones are not quite the same length, so they don't fit perfectly. But you can see how when we have these two bones articulated at the distal end, we've kind of almost formed a little cup-like structure between the two bones and then the lateral malleolus and the medial malleolus. And that is ultimately where we are going to articulate with the bones of the ankle. So coming back to this articulated model here, again, you can see kind of that little cup-like structure that these bones form in order to articulate with the talus bone. So the talus bone is this bone right here. And this is going to form the ankle joint, also known as the talocrural joint. Why would it be called that? Talo, because this is the talus. Crural, because recall that crural refers to the lower leg. So for the next part of this demonstration, I'd recommend that you pull up figure 3.9 from your lab manual that is going to show the foot. And that way we'll get a chance to look at all those bones. We can divide these bones of the foot into 3 main groups. There are the tarsals, or the bones of the ankle. There are the metatarsals, or the bones of the foot. And then the phalanges, or what we would commonly refer to as the toes. And I've colored those in as your lab manual asks you to do. And now we're going to walk through all of those different bones, but looking at the model and in those 3 groups. So let's go ahead and start with the tarsal bones. There are 7 tarsal bones in the ankle, and here you can see again this articulated foot that we have, and so you can clearly see we've got our tibia and our fibula. If we're looking down the leg, and we can see where those are articulating. We've already mentioned that both of these, the tibia and the fibula, are articulating with the talus. So the tibia is articulating with both the proximal surface of the talus and then also kind of that medial side of it, while the fibula is primarily articulating with this lateral side of the talus. The calcaneus is going to be just below that. The calcaneus is the heel bone. It's the largest of all those tarsals, and it's responsible for transferring most of your weight to the ground when you're just in a normal stance. And if you look at the posterior part of that calcaneus, you're going to see it has a very large rough surface, this rough projection here, and that is where the calcaneal tendon is going to attach, or the Achilles tendon, as you may have heard of it. As we continue on through the foot, you're going to see that as far as the remaining bones, the calcaneus is going to articulate with the cuboid, the talus is going to articulate with the navicular, and then the navicular is going to articulate with three other bones right here that are referred to as the cuneiforms. The cuneiforms, we have a medial cuneiform, an intermediate cuneiform, and then the lateral cuneiform. Note also how metatarsals 5 and 4 both articulate with the cuboid, while 3, 2, and 1 each have their own cuneiform that they're going to articulate with. So as far as those metatarsals, there are the metatarsals are 5 long bones that are located in the region of the foot that essentially doesn't include the toes. And these are just simply identified by the Roman numerals beginning with the most medial. So this right here is metatarsal 1, metatarsal 2, metatarsal 3, metatarsal 4, and metatarsal 5. And then last but not least are the phalanges, or the toes. Phalanges is plural. The term phalanx is a singular. And each of these are identified not only by the digit number, but also whether they are proximal, middle, or the distal phalanx of that digit. So let's consider first what is going on here with digits 2 through 5. So if we look at these digits, I'm going to pull up 2 here for a second. You're going to see that the toe actually consists of 3 different bones. So we've got, sorry, these are kind of getting in the way a little bit here. There we go. So we've got one small one at the end, one that's in the middle, and then one that actually connects to the metatarsal itself. This is what we refer to as the distal phalanx, the middle phalanx, and then the proximal phalanx. So as far as where this is the most distal part of the leg. So that's a distal phalanx, middle phalanx, and proximal phalanx. Specifically, these ones that I happen to have been pointing out are from digit 2. So again, this is the distal phalanx of digit 2, the middle phalanx of digit 2, the proximal phalanx of digit 2. Distal, middle, and proximal for digit 3, distal, middle, proximal for digit 4, distal, middle, and proximal of digit 5. But notice when we get to digit 1 that there are only 2. There is no middle phalanx with essentially the big toe. Rather than just calling it digit 1, we also have a specific name for that. We refer to it as the hallux. And so these bones would be referred to as the distal phalanx of the hallux and the proximal phalanx of the hallux. I'd like to draw your attention to a figure from your textbook to discuss these joints and articulations that are part of the foot rather than the model itself, because I think it's a little bit easier to initially distinguish them here. So recall we said that there are 3 groups of bones in the foot, the tarsals, the metatarsals, and the phalanges. And we can also consider then there to be 4 groups of joints. So we start out by the ones called the intertarsals, intertarsal, between the tarsals. So those are all the joints, all the articulations in which the tarsal bones are articulating with each other. As we continue to head distally, then we're going to get to the tarso-metatarsal joints. And there are 5 of those. So one at the articulation with each metatarsal. Then, as you can probably imagine, we have to have a point where the metatarsals are going to articulate with the phalanges, and there's going to be one of those at each digit. And those are the metatarsophalangeal joints. You might sometimes see that abbreviated as MP joints, but we do want you to use the full name. And then the interphalangeal joints. Those are all of the joints that are either between a distal and middle phalanx, between a middle phalanx and a proximal phalanx, or between the distal and proximal in the case of the hallux. And all of those are the interphalangeal joints. So we've been pointing out a lot of these articulations along the way. But you might have noticed that there's a very large table at the end of this lesson where it's asking you for a little more detail about these articulations. So a super, super quick little review for you here. When we were talking about articulations, you were introduced to the concept of there being structural classifications and functional classifications for articulations. So again, fibrous joints are one type of structural classification, and there are subclassifications for those. A fibrous gomphosis is referring to the joints between the teeth and either the mandible or the maxilla. A fibrous suture is only going to be found in the skull, so we're not going to worry about those for a while. But then there's the fibrous syndesmosis, and that is an example of a joint that has an interosseous membrane in between. And we did notice that while this figure from your textbook is showing this interosseous membrane between bones of your arm, we already pointed out that this exists between the tibia and the fibula as well. In addition to these structural classifications, we can classify things based on how mobile they are. So that is its functional classification. A synarthrosis is a joint that essentially has no movement associated with it. You don't want your teeth to move around. You don't want the bones of your skull to move around. Those are both synarthrotic joints. They don't move. A syndesmosis, however, is an example of an amphiarthrosis. And an amphiarthrosis is a joint that has a slight bit of movement. It's not fully mobile, but it does allow for a slight bit of movement. So that's one of our classifications. Our next structural classification would be a cartilaginous joint. So when we talk about cartilaginous joints, we also have two subsets. Some of those cartilaginous joints occur where bones are joined by hyaline cartilage, and one of those joints would be called a synchondrosis. You also have some bones that are joined together by a different type of cartilage called fibrocartilage, and an example of that would be a cartilaginous symphysis. We have already been introduced to one of those, one of which is the pubic symphysis, where the two pubis bones of the right os cox and the left os coxa come together. Hyaline cartilage is very hard cartilage. It doesn't move around a lot, and so that's why any type of cartilaginous synchondrosis would be functionally classified as a synarthrosis, while a cartilaginous symphysis does allow for a little bit of movement, and because of those fibrocartilage is not as hard, it's a little bit softer, so that would be referred to as an amphiarthrosis. So far with our structural classifications, we've had fibrous joints, cartilaginous joints, and then the third type structurally were the synovial joints. All of those synovial joints, while there are various subtypes, hopefully you recall there are ball and sockets, pivot joints, condylar joints, saddle joints, planar joints, and hinges as well. All of those are considered to have a lot of mobility with them. So any synovial joint is functionally classified as a diarthrosis. What we would like you to do is, as an exercise, this is just showing you a little overview of that table 3.1 from your lab manual. This gives you the spot to note for each of those anatomical joints that you've been presented with. I want you to mark in there and fill out what is the structural classification and type. So don't just put fibrous, cartilaginous, or synovial. What type of fibrous, what type of cartilaginous, what type of synovial as well. And then I want you to have the functional classification. So is it a synarthrosis, an amphiarthrosis, or a diarthrosis? What are the articulating parts in the bones, and then what actions are possible? This is a very important table because you're going to then be referencing this in the future as we look at muscles that are working on those specific joints.